Hello, my name is Rachel Kurtzman. I'm a research scientist at NORC at the University of Chicago, and on behalf of ARC and the Clinical Decision Support Innovation Collaborative, I'm presenting our work on the planning and reporting tool for patient-centered clinical decision support implementations. I will start with background on the ARC Clinical Decision Support Innovation Collaborative, or CDSIC. Established in 2021, the CDSIC creates a learning community to share and advance knowledge, resources, and methods for patient-centered CDS, promote the practice and adoption of high-quality PC-CDS, and advance standards-based CDS that can be shared and scaled across the U.S. healthcare ecosystem. Patient-centered clinical decision support, or PC-CDS, is a form of CDS that supports care for individual patients or specific patient populations and significantly incorporates patient-centered factors related to knowledge, such as evidence-based findings from patient-centered outcomes research, data such as patient-generated health data or patient-reported outcomes, delivery that directly engages patients or caregivers via apps or patient portals, and use that involves patients and caregivers. To advance the evidence base for PC-CDS, implementation teams must consistently and comprehensively describe how PC-CDS was developed, used, maintained, and evaluated. This helps others replicate successes, synthesize best practices, advances knowledge to improve health and healthcare, and disseminate biomedical knowledge. The PC-CDS planning and reporting tool is composed of two documents. First is the fillable tool, in which users can describe details of how each PC-CDS implementation task and associated patient-centered activities were addressed by their approach. The second is the detailed user guide, which provides definitions and descriptions of the PC-CDS implementation tasks. The tool and user guide aggregate existing CDS implementation guidance and implementation science and evaluation frameworks to provide a unified resource for reporting PC-CDS research in support of a learning health system, and addresses a key gap in existing PC-CDS implementation guides and frameworks by incorporating preliminary guidance on corresponding patient-centered activities for implementation tasks. Implementation teams can use the user guide and tool during and after implementation of PC-CDS to produce a comprehensive report describing their work. Such reports can foster synthesis of PC-CDS implementation best practices and support others replicating implementation successes across settings. Potential users of the tool include researchers, EHR and app developers, PC-CDS users and evaluators, patients and caregivers, and others interested in PC-CDS. The planning and reporting tool was developed based on a previous CDSIC product, the Planning, Implementation, and Reporting Checklist, which was developed through synthesis of information from a targeted literature review and key informant interviews with 5 potential end users of the tool who provided feedback on content, design, and potential usefulness of the tool. To update the planning and reporting tool, we conducted additional key informant interviews with 2 PC-CDS experts to identify areas for refinement. Suggestions included reducing jargon, restructuring columns, and adding definitions. We made these initial edits and then conducted user testing with 6 novice and expert PC-CDS researchers to understand how users with different experience use the tool and guide. We synthesized a list of priority updates based on this feedback and edited the tool and user guide. The PC-CDS planning and reporting tool is intended to support PC-CDS implementation teams describing their interventions across these 4 sections. The planning and reporting tool is a fillable PDF document, and below is an example of the tool. Each of the 4 sections is color-coded for visibility. In the left column is the task, and there is a separate row for each task within a section. In each task row, there are 2 checkboxes, task addressed and not applicable, because not every task is relevant for every PC-CDS implementation. The middle column includes the task description and associated patient-centered activities, and more detail is included in the user guide. The right column is a fillable field where users can provide details on how their project addressed the task and patient-centered activities as shown here. The user guide accompanies the planning and reporting tool and provides a description of each section and task along with patient-centered activities. This is a screenshot from the planning and needs assessment section of the user guide, which starts with an overview of the section and then a description of the task area and task. There is an icon which notes the patient-centered activities to consider for each task. This user guide provides information to help users, both experienced and new to CDS, understand the tasks important to the planning, design, implementation, and evaluation of PC-CDS interventions. In conclusion, the PC-CDS planning and reporting tool and user guide are resources available to assist implementation teams during and after implementation of CDS to produce comprehensive reports describing their work. This is the first practical resource for planning and reporting on PC-CDS implementations, supporting dissemination and transparency of CBK. You can access these documents by scanning the QR codes on the screen. Thank you.
Hello, my name is Caroline Peterson. I am a senior research associate at NORC at the University of Chicago. On behalf of the Agency for Healthcare Research and Quality Clinical Decision Support Innovation Collaborative, or CDSIC, I'm presenting our work exploring the collection and use of patient preferences data in patient centered clinical decision support, or PCCDS. Established in 2021, the CDSIC serves as a learning community to share and advance knowledge, resources, and methods for PCCDS. It also promotes the practice and adoption of high quality PCCDS and advances standard based CDS that can be shared and scaled across the US healthcare ecosystem. To frame this presentation, I want to take a moment to define PCCDS. PCCDS is a form of CDS that significantly incorporates patient centered factors related to knowledge, such as leveraging evidence based findings from patient centered outcomes research, data, such as incorporating patient generated health data or patient reported outcomes, delivery, or directly engaging patients or caregivers via apps or patient portals, and use or facilitating bidirectional information exchange to support patient centered care. I would also like to define two terms I'll be using throughout the presentation: patient life flows and clinical workflows. Patient life flows are activities both within and outside of healthcare encounters that impact an individual's health, such as taking self care actions or completing activities of daily living. Clinical workflows are a series of steps required to perform a specific clinical activity. Here, workflows represent the intersection of the decision support with the tasks of the care team, such as preparing for clinician visits or documenting decisions. Patients interact with the health system in different ways, presenting multiple opportunities for their preferences to be collected. These preferences can then influence the care they receive. The discussion and consideration of these preferences in healthcare decision making can enhance patient satisfaction and improve health outcomes. One potential method to address patient preferences in health decision making is to integrate preferences into PCCDS. However, our limited understanding of how patient preferences data are collected and used in patient life flows and clinical workflows limits health systems' ability to harness this data for PCCDS. In response, we conducted a literature review synthesizing 63 publications and a series of 9 key informant interviews. Interviewees included researchers, an internist slash clinical informaticist, and a patient advocate. Together, these activities helped us identify the methods and time points for collecting and using patient preferences for PCCDS. Using these findings, we developed swim lane diagrams, or tools for representing healthcare related workflows that visualize opportunities for collecting patient preferences before, during, and after the clinical encounter. Each diagram focuses on a unique clinical scenario. Here you see the diagram that centers on a patient discussing treatment options for breast cancer. From the top of the diagram, the patient caregiver lane represents the patient who is receiving healthcare and providing preferences, along with any caregivers. Patient caregiver activities also include receiving information shared by the patient facing technology, which is the green lane below. This lane represents a patient portal or patient facing app that can be used as a PCCDS tool. Preferences shared by the patient or caregiver via this tool can be accessed and reviewed by the care team. The yellow patient caregiver and care team interaction lane represents the clinical visit where the patient and care team discuss the patient's preferences. The orange care team facing technology lane shows a CDS tool that is specifically used by care team members, such as the electronic health record. Finally, the care team lane represents the clinical team members who are responsible for the patient's healthcare and are involved in reviewing the patient's preferences and following up as needed. Through this work, we also explored considerations for optimizing these processes for both patients and clinicians. These include encouraging patients to share their preferences by having the care team communicate the purpose and value of preference data and gathering preferences that are important to patients' care. Opportunities to reduce burden for clinicians include delegating the collection of patient preference information to other care team members, such as medical assistants or nurses, and ensuring patient preference data are accessible to clinicians, such as by creating a standardized space for recording preference information. Finally, we identified 7 short and long term opportunities to advance this effort. Short term opportunities include promoting the importance of including patient preferences in PCCDS tools and educating clinical staff to better recognize and accommodate varied patient preferences. Long-term opportunities include exploring processes that capture changes in patient preferences over time, as well as prioritizing the implementation of robust tools for gathering patient preferences for use in clinical care. Together, this work supports optimizing the collection and use of valuable computable data. Putting this cutting-edge preference data into action can offer more personalized care and foster collaborative patient-clinician relationships. You can access the full report by scanning the QR code on the screen. Thank you for your time.
Hello, my name is Avantika Shah. I'm a research scientist at NORC at the University of Chicago. I'll be presenting the action plan to collect and use social determinants of health data and patient-centered clinical decision support. This work was developed by the Agency for Healthcare Research and Quality-funded Clinical Decision Support Innovation Collaborative. I want to begin by providing a very brief background on the our Clinical Decision Support Innovation Collaborative, or CDSIC. Established in 2021, the CDSIC creates a learning community to share and advance knowledge, resources, and methods for patient-centered CDS, promote the practice and adoption of high-quality BCCDS, and advance standard-based CDS that can be shared and scaled across the U.S. healthcare ecosystem. What is patient-centered clinical decision support, or PCCDS? It is a form of CDS that supports care for individual patients or specific patient populations and significantly incorporates patient-centered factors related to knowledge, data, delivery, and use. I want to provide a brief background for this action plan. The increasing recognition of social determinants of health, social risk factors, and health-related social needs highlights the impact on health outcomes. Integrating SDOH data into PCCDS can enhance patient-centered CDS. While prior work by our collaborative and the Gravity Project has explored SDOH data standards, practical challenges in advancing the use of SDOH data for PCCDS remain. Our goal was to identify key needs, challenges, and opportunities to further integrate SDOH data into PCCDS. We began by conducting a literature review of 78 publications, which helped us to develop an initial list of needs, challenges, and opportunities. Following this, we conducted 7 key informant interviews with clinicians, informaticists, researchers, and patient advocates to refine these insights. We identified 5 needs related to the collection and use of SDOH data into PCCDS. First need is to identify clinical guidelines that incorporate SDOH to develop PCCDS tools. Second need is to understand what SDOH data PCCDS should incorporate. Third need is to routinely capture SDOH factors and establish PCCDS workflows to support social risk-informed care. Fourth need is to standardize representation of SDOH data to support data capture, integration for PCCDS development. Finally, fifth need is to measure the effectiveness of PCCDS tools that incorporate SDOH. We identified some challenges across 5 needs and have articulated 11 opportunities. So the first challenge that surfaces is that there are few clinical guidelines that incorporate SDOH in a way that can be consistently translated into PCCDS tools. And those with lived experiences are rarely involved. Our first opportunity is that key actors that develop these clinical guidelines should prioritize the inclusion of SDOH. Second, clinical guideline and CDS developers should include those with lived experiences in the development of clinical practice guidelines and co-design process. Another challenge we identified is that evidence on which SDOH data to incorporate into PCCDS is still limited. Third opportunity is that CDS developers should include input from patients, caregivers, and clinicians to identify SDOH and health-related social needs that may be impacted by PCCDS. Fourth, CDS researchers must prioritize investigations in this area. Other challenges that surfaced are that patients are hesitant to share SDOH data due to stigma and lack of trust, and clinicians face challenges in integrating this information into care plans without adding additional burdens. Our next set of opportunities include healthcare systems should follow transparent practices by clearly outlining how SDOH data will be used, stored, and protected. Patient and user-centric approaches should be deployed to develop implementation workflows for documentations. And finally, engage PCCDS stakeholders at all stages of the life cycle so recommendations are specific and actionable. Related to the needs for standards, there's a lack of uniform standards adoptions for SDOH data. And while on the other hand, standardization may miss important nuances that are inherent to this information. Our 8th opportunity proposes to develop comprehensive training programs and resources so healthcare organizations can adopt SDOH data standards. For the 9th opportunity, individual healthcare systems can work with EHR vendors to tailor their screening processes and including some custom fields in line with their preferences and population's needs. Finally, there are no common metrics to evaluate the effectiveness of CDS tools that incorporate SDOH data. Our 10th and 11th opportunities are that PCCDS researchers should identify measures and metrics to evaluate these tools and develop methods and prioritize investigations of SDOH-related PCCDS interventions to expand research in this area. In conclusion, SDOH data into PCCDS can advance social risk-informed care, enabling more personalized and proactive decision-making. The 11 key recommendations within this action plan emphasize collaborations across these stakeholders. Finally, addressing patients' health-related social needs goes beyond healthcare and requires a cross-sector approach. If you're interested in learning more about this topic, please access our full report using the QR code on the screen. Thank you for your time today.
Hi, my name is Krista Heaney-Holes. I'm a research scientist at NORC at the University of Chicago. On behalf of the Agency for Healthcare Research and Quality, Clinical Decision Support Innovation Collaborative, I'm pleased to present our work exploring strategies to overcome challenges when integrating computable biomedical knowledge into patient-centered clinical decision support. Established in 2021, the CDSIC creates a learning community to share and advance knowledge, resources, and methods for patient-centered CDS, promotes the practice and adoption of high-quality patient-centered CDS, and advances standards-based CDS that can be shared and scaled across the U.S. healthcare ecosystem. Patient-centered CDS is a form of CDS that significantly incorporates 4 patient-centered factors: knowledge, patient data, delivery, and use. Knowledge refers to the use of comparative effectiveness research or patient-centered outcomes research findings. Data focuses on the incorporation of PGHD, patient preferences, health-related social needs data, and other patient-specific information. Delivery refers to directly engaging patients and/or caregivers across different settings. And finally, use focuses on facilitating bidirectional information exchange in support of patient-centered care, including shared decision-making. Throughout the CDS lifecycle, myriad challenges exist to realizing the benefits of patient-centered CDS. Each challenge requires careful consideration and tailored solutions to ensure successful deployment and utilization. ARC has funded several CDS projects to address these challenges and implement effective solutions. We examined 9 real-world PC-CDS implementation projects selected from ARC's Digital Health Research Program. We reviewed project documents and conducted key informant interviews with project team members to aggregate project insights and provide practical guidance for implementers. Identified challenges to integrating computable biomedical knowledge and patient-centered CDS fell into 3 main areas: knowledge generation, interoperability standards, and data infrastructure challenges. Challenges related to knowledge generation centered on a scarcity of resources and expertise for integrating FHIR with patient-centered CDS, differing preferences for how to translate PCOR evidence into CDS, and the costly nature of local customization. Interoperability challenges, including inadequate standards for data exchange, including insufficient implementation of standard terminologies, and the lack of syntactic and semantic interoperability. For example, variations in the FHIR standards supported across different EHRs, as well as gaps in the FHIR standards themselves related to supporting population-level queries and accessing data from both the EHR and external sources. Data infrastructure challenges center on high costs associated with application licensing and hosting fees, and insufficient functionality of patient-centered CDS in EHR testing environments. These challenges are amplified in the context of patient-centered CDS, given the use of FHIR-based apps and the need to write patient-provided data to the EHR. We identified 3 strategies project teams implemented to address technical deployment challenges. First, identifying patient-centered CDS integration expertise pre-implementation supports resource allocation and can inform decisions regarding system architecture. Second, implementing API middleware helps to address the incomplete implementation and adoption of FHIR by EHR developers. Third, evaluating data quality pre-implementation facilitates assessment of the adequacy of the data and logic required for patient-centered CDS, particularly for data that leverages FHIR. Efforts to enhance the technical infrastructure to implement and scale patient-centered CDS should focus on encouraging FHIR adoption and enhancing FHIR capabilities, developing resources and workforce capacity for patient-centered CDS integration expertise, and using interoperability standards such as Smart on FHIR, USCDI, and CDS hooks. By implementing the suggested solutions and recommendations outlined in this report, stakeholders can harness the full potential of patient-centered CDS to improve patient outcomes and enhance the quality of healthcare delivery. You can read the full case study report by scanning the QR code on the screen. Thank you, and I welcome any questions.
Hi everyone, my name is Karen Fortuna. I'm an assistant professor of community and family medicine at Dartmouth, and today I'm going to be presenting on the Partnership Academy, which is an experiential community-based participatory research experience in which we partner with patients, community members, policymakers, and industry to come together to develop different programs of research. Now, why is this important? So when we build different types of products, it's challenging to get individuals to engage and use these types of products. So from the science of engagement, we know if we partner with individuals who are the end users throughout the entirety of the software development lifecycle, that we have a higher likelihood of increasing engagement, uptake, and dissemination across systems and services. So within the Partnership Academy, individuals will come together. We work with them to map out who should be at the specific table. So let's say that we're developing using different data sources to develop and predict early mortality with people with a diagnosis of serious mental illness. So here we first map partners to see who should be at the table. We have an international collaborative where we work with the large payer systems, industry scientists, health systems administrators, policymakers, caregivers, and patient partners. People then, we figure out who are the individuals who have levers who can help us develop and integrate these types of programs and services. Individuals come together for 8 hours, generally day 1 and day 2. We review the state of the science on whatever topic that we are working on, and together we integrate something which is a community engagement technique called Story with a Gap. Here, we present a story around someone related to early mortality, and we have a huge gap in the middle. So we say there's a patient partner, they have a challenging life and lifestyle, they have multiple chronic health conditions, and here's our gap. And then they live a long, healthy life. And so here we generate and brainstorm, how do we fill that gap? And then we anonymously rank those solutions to filling that gap. And then day 2, we present those materials, and then we do a Delphi panel for 100% consensus, especially with vulnerable populations. And within that, this is a consensus building technique where we rank what is the most important and most sustainable solution. And then we engage on that through developing different types of grants with individuals. From that group, we have a formation of co-production teams where we list and prioritize these patient-generated research studies, which have included identifying variables related to early mortality and really changing the trajectory of our entire work. And then, so from this, we offer technical assistance around grant writing or manuscript writing, and then also monthly seminars on the state of the science of community engagement. Now, within this, one of our populations that we have worked with, we went from a 22K initial investment, and then after going through a partnership academy, specifically related to early mortality, we had a 31% increase towards the programs and services, which were related to grant applications from these co-production teams that we have had. And so we work with many different types of populations. Currently, we're working with individuals around head and neck cancer to expedite care in rural communities. We're also working with individuals to facilitate hepatitis C screening among women in rural areas. We're also working with certain states to develop different types of programs and resources to support youth around jail diversion programs. And then we've also doing some work in rare disease as well. And part of this is identifying those variables and thinking about different ways that we can address long-standing health disparities with individuals. So if you're interested in learning more, please feel free to contact me and the team, and there's a picture of all of us. And then we also have a website as well. Thank you so much for the opportunity to present. Looking forward to hearing from individuals.
Good morning, everyone. My name is Sunny, and today I'll be presenting on the role of peer support for family caregivers of individuals with dementia, focusing on the transition from in-person to digital delivery. Family caregivers of people with dementia experience high levels of stress, depression, and even physical health decline. In fact, the Centers for Disease Control and Prevention found that over 50% of caregivers self-report a decline in their mental and physical well-being. While traditional in-person peer support has been a fundamental component of caregiver programs for decades, many caregivers find these interventions inaccessible due to time constraints, geographic barriers, and financial limitations. This is where digital peer support interventions, particularly those delivered through mobile health platforms, offer a new avenue for accessibility and scalability. However, digital peer support programs also introduce new challenges such as digital literacy barriers and socioeconomic disparities. My presentation will summarize the key findings from our narrative review on this topic, examining both the benefits and limitations of these interventions. Research has consistently demonstrated that peer support provides psychological benefits for caregivers. A meta-analysis by Chin et al. Examined 30 studies conducted between 1998 and 2009 and found that group-based peer support significantly improved well-being, reduced caregiver strain, and provided emotional relief. The study found that longer interventions, those lasting over 8 weeks, and smaller group sizes, typically between 6 to 10 caregivers, yielded the best results. Additionally, Smith et al. Examined one-on-one peer mentoring programs and found that caregivers who received individualized peer support report lower levels of depression and improved coping skills over 6 months. These findings highlight the significant psychological benefits of peer support, whether delivered in a group or individual format. In addition to traditional in-person support, digital peer support interventions have emerged as an alternative, particularly for caregivers who face barriers to attending in-person meetings. Han et al. Evaluated a WeChat-based peer support program involving 154 caregivers in China and found significant reductions in stress and depression, although the effect sizes were relatively modest. Similarly, Zhang et al. Developed the CareDoc app, which integrates mentalizing imagery therapy and text-based peer chat rooms. Preliminary findings suggest high feasibility and acceptance among caregivers. Another notable example is the CARES smartphone app, developed in collaboration with both professional and peer caregivers. Collins Pisano et al. Conducted a pilot study with 9 caregivers and found that the app was not only highly usable and acceptable, but also contributed to reduced caregiver strain. Despite these positive findings, significant barriers remain in the implementation of digital peer support. One major challenge is the digital literacy gap, particularly among older caregivers who may struggle with navigating digital interfaces. Furthermore, Danes, Kearney, and Gallagher found that most participants in online caregiver support groups were white, educated women, highlighting the exclusion of caregivers from lower income and racially diverse backgrounds. Furthermore, Hopwood et al. Found that caregivers in rural or lower income settings were less likely to engage in digital peer support due to unreliable internet access. In conclusion, peer support interventions, whether in-person or digital, provide significant psychological benefits for caregivers, but challenges such as digital literacy and equitable engagement should be addressed. Addressing these issues will ensure that all caregivers can benefit from peer support interventions. Thank you, and I welcome any questions.
Hi, my name is Samantha Foreman, and thank you so much for accepting my abstract into MCBK. In addition to thank you for everyone for tuning in and joining me as I go through my research. My research is titled Towards Semantic Interoperability in the Coding of Patient Engagement Questionnaires using SNOMED CT. For background, SNOMED CT is a structured vocabulary slash clinical terminology that has over 350,000 codable concepts, medical terms, and synonyms. This shows just how extensive SNOMED is, which is great, but it can also lead to variability in coding clinical concepts amongst coders. This variability can make it very challenging to obtain accurate data capture, as there are many different codes that may represent the same things, which leads to difficulties in data reuse, since data may appear not fully encompassing of the clinical concepts within a patient's medical chart, or data may appear fragmented. Semantic interoperability goes over the ability of systems to share data with a clear and shared meaning, which ultimately ensures that exchange information between systems is understandable. This is crucial when sharing health data between systems. Lack of accurate data capture ultimately inhibits data sharing and reuse in categories such as research, compliance, registries, and epidemiology. We ultimately need higher levels of intercoder agreement for accurate and consistent coding, which is important as it drives improvements in clinical care. For methods, a patient engagement questionnaire from Moffitt Cancer Center in Tampa, Florida was coded to match clinical terminology within SNOMED CT. There are 27 question answer pairs total with varying amounts of answer choices within each question. You'll see examples in figure 1 of the question answer pairs. So for example, have you had any health symptoms in the past 3 months? Check all that apply. So some of the answers were fever, decrease in appetite, increased appetite, and sleeping poorly. We basically had to figure out how to best and most accurately code these answers within question answer pairs to SNOMED CT. Some of the challenges that we saw were that there are questions that had multiple concepts within a single question, as shown here in figure 1, where the same question, but it'll say check all that apply and have chest pain, discomfort, tightness, and angina. Another challenge that we faced was that there were open-ended questions. So here in figure 1, where it says how many cigarettes on average do you or did you smoke per day, there aren't any map codes for fill in the blank. A final challenge that we faced is that there are many qualifiers that require post-coordination that were ultimately wanting to be used by Moffitt Cancer Center. And here is a decision tree for how we try to map our clinical terms to SNOMED CT without using post-coordination. For our results, we found that 84% of terms matched to SNOMED CT, which shows just how in-depth SNOMED CT is. There were 16% of question answer pairs that had no match or contained a free text box that was unsupported by SNOMED CT. And then a third of initial questions on the patient engagement questionnaire required post-coordination. Some of our conclusions were that considering semantic interoperability early in instrument design is crucial, as it allows a health organization to look at possible SNOMED CT terms related to the intended concept prior to building the question. Inconsistencies in coding are often due to different post-coordination of concepts, which help us identify a best practice of limiting post-coordination. In addition to less free text boxes and only having one clinical concept within a single question, as shown in figure 3. So for example, they might ask how many cigarettes on average do or did you smoke per day, rather than leaving that as a fill in the blank. A healthcare organization can look at different SNOMED CT clinical concepts pertaining to that. And you'll see here that suggestions that were brought up were different SNOMED CT terms and IDs that one can choose rather than leaving it to fill in the blank. Some of the impacts are that there are improvements in data capture that allow for data reuse in topics such as research, compliance, registries, and more when these best practices are taken into account. And further studies may focus on robotic process automation, also known as RPA, with these suggestions implemented within algorithms in the future. Thank you so much for listening in, and I appreciate it so much. Have a good one.